Welcome to Conference Highlights, recorded in front of a live audience at an evidence-based perioperative medicine, that's EBPOM conference. EBPOM are world leaders in perioperative education, so why not join us at our next meeting with a special discount for Top Med Talk subscribers. Look us up on www.ebpom, that's EBPOM.com. Top Med Talk.
My name is Ramani Munasinger. It's my great pleasure to chair this first session on big challenges in perioperative care. Our first speaker is my friend and colleague, Dr. Hare. Sarah is a consultant anaesthetist at Medway Maritime Hospital in the UK, and she is the National Clinical Lead for the National Emergency Laparotomy Audit, which you've heard a lot about already at this meeting. But Sarah this morning is going to talk about QA, QI and patient involvement. Welcome, Sarah.
Good morning, everyone. So it's really, really good to be starting off today, which is the 70th anniversary of the National Health Service, focusing on patients. Because, let's face it, they are the reason that we get out of bed every morning and in the middle of the night. It's why we miss birthdays, our own and our children's and our families', Christmases, and occasionally your wedding is missed because you're looking after a patient. So to focus on them this morning is really, really important. I have doctored my title slightly, sorry, Rams, because QA is quality assurance, and patients can be involved with that, but I want to focus a little bit more on quality improvement. And you've all heard about NELA now. I say NELA, many of my colleagues say NELA. I think it depends on where you are in the country, but we'll stick with NELA for this morning. And we're currently writing the fourth report of the National Emergency Laparotomy Audit, and we'll publish that in September. And it's now one of the world's largest databases about what happens to our patients when they have an emergency laparotomy. And we've just finished off analysing data on about 24,000 patients for year 4 to see what's really happening to them when they come into our hospitals, 183 hospitals across England and Wales, when they come in as an emergency for this really high-risk surgery. And over the years, we've developed slightly. We started off as just an audit, benchmarking performance against some standards, some nationally recognised standards, and reporting back to teams and their hospitals and their trusts and their boards. So providing some kind of assurance that the care that patients are receiving matches some kind of standard. But as we've developed the audit, we're moving more and more into promoting quality improvement. And to this end, NELA is trying to promote the use of national data at local level to drive change for your patients. And we appreciate that NELA is a big database, and we appreciate that that can be quite difficult. And just as me, as a jobbing anaesthetist in a district general hospital, knows that there's a lot of questions to be filled in. But by encouraging local teamwork, encouraging multidisciplinary teams, so surgeons working with anaesthetists, working with radiologists, working with our geriatric colleagues, working with our non-clinical colleagues and our theatre staff, we really want people to be using that national data at local level to support the change they want to do. And on our website, there's toolkits, there's run charts, there's the great quality improvement videos made by my friend Carolyn Johnston and narrated by her in her beautiful lilting accent, and they're all there and available. But this is just part of what we need to do. And QI is becoming something that we're all quite comfortable with, and we've heard the results of EPOC yesterday, and I'm looking forward to hearing the rest of the outcomes from that. And we're quite comfy with it. It's a term that we bandy around and use a lot now. But the next big challenge is how to make that really meaningful for our patients. Now, there's lots of terms surrounding this. Co-design of care, co-production of care, co-delivery of care. All of these imply really the same thing. This is the involvement of patients from an early stage in the design and the production and the delivery of care. So involving them is quite well established in research and recognised as being very important and very full of value. But in quality improvement, we're at early days in doing this. And one of my favourite quotes that I've read is by David McNally, which says, actually, never mind, do mind co-design, co-production, co-delivery, but what's really important is to understand that engaging your patients is a process where you turn QI from something that's being done to them, or done about them, or done for them, into a process that's being done by them or done with them. So patients start taking some ownership about the quality improvement that's occurring within their hospital, their own hospital. So they're engaged. they're enabled, and they're empowered to make a difference and inform the change that we want to do. We're not just consulting with them. But I think one of the more difficult things to then get our heads around, and perhaps we haven't answered yet, is with ownership and with directing care comes accountability. And as we move forward in this quite new area of engaging patients properly with quality improvement, we have to understand how we're going to support them in the way they feel about their accountability for changing care. But what is great is when we talk to patients about quality improvement, they're already doing it. And they are our most expert group of people who we can consult. If you think about just simple process mapping, which is a key tool when you're doing your quality improvement, and we talk about how we will walk the walk that patients do so we can understand where there's areas that we can change, where there's loss of value, where we need to start some lean methodology. And we do that, don't we? We'll walk it once. Some people might even walk it twice, and you'll ask people what happens. But the real people who are doing that are our patients. They're process mapping simply by being the experts of experience. How many of you have had surgery? How many of you have had to get your bloods taken before you go to have your surgery and gone to pre-assessment? How many of you walk miles around a hospital to go and have your pre-assessment, have your ECG, to go and have your blood test, and then you have to walk all the way back again because you've forgotten the slip that you needed and you've left it at the front desk or you weren't given it? That's true process mapping. And once we start listening to our patients about that, so this is a really basic process map, which you probably can't even read, about coming into ED and getting your CT scan. It's only by talking to patients that we really appreciated the big delays and where we had to target and change what we were doing and ask them what was really happening. So they are our experts and we should use them. And in fact, the Coalition for Collaborative Care, which is a great organisation promoting this work, has a really great quote. So I work in Medway Maritime Hospital, and we're a really special hospital. We were one of the only hospitals, we were one of the 14 Hare hospitals, and we're one of the hospitals to have been in special measures the longest for 2 years. We're very special. And I don't think they quite knew what to do with us, frankly. But anyway, for all the wrong reasons, we were in the press. Now, when you're a very special hospital, lots of very expensive special management consultants and organisations like to get involved with helping you stop being so special. And we have probably paid millions trying to not be special. And I probably shouldn't say that on a national platform, but we all know it. But just from one encounter, so in one of which I'm going to talk about our patient support and engagement groups for emergency patients, a gentleman sent this back to me in the post. The discharge process needs streamlining. Some patients told they could go home at 9 a.m, still waiting for various items at 8:30 p.m. We've paid millions to find that from management consultants and have that written in a formal document. And yet in one day and a cup of tea with a wonderful chap in his late 70s, early 80s, we got it written down in fountain pen. I would say that that is what is incredibly valued. Our patients know. They know where the change needs to be done and they can inform it. And most of them are experts in how it can be made better. So there's a ton of benefits involving patients in quality improvement. We know that if patients are engaged with informing change and they design pathways, that they'll probably do those pathways better. And we have experience of that in things like giving them their drugs to take home with them, what medications they need to take after surgery. If they're involved and informed and understand that and they've designed how you take it, they're more likely to do it. Interestingly, they can help us inform the concept of always events. This is something the Picker Institute and other institutes have been promoting. An always event is something that is so important to patients and their care that it should always happen for every patient, every time that someone comes in to have that particular procedure, intervention or consultation. An always event. So they can help us understand what are our always events for our particular improvement drive that we're trying to do. Of course, it will improve shared decision making. Of course, we heard yesterday about some great trials where patient involvement and engagement has informed research. We learned yesterday that patients much prefer exercising in groups and being together. So that's important because if we've learnt that from our patients, rather than us as clinicians assuming that they might not want to be seen when they exercise because they go red in the face and they're a bit embarrassed, if we hadn't listened to our patients, then we wouldn't have had such successful outcomes. So it's full of benefits. But if we're going to do it in quality improvement and engage and involve our patients in some shape or form, then we have to understand that there needs to be some standards attached to it. And there's none really developed, but we've tried to map in our patient involvement with quality improvement some standards to make it work. And these are just adapted from the well-established ones for public involvement in research from involve.org. We need to make sure that lots of people can take part easily. So, underlying that, we need to understand how they can be a part of that. Can they get to the hospital? Do they need our help parking? Do they need our help understanding the buses? Do they need us to pay their parking fees? Do they need us to help them up the stairs? We need to understand how we can involve everybody. Do we need to run focus groups and patient support groups and engagement groups with QI in the evenings? Because they can't go because some of your population are at work. So we have to understand how we reach these patients as well. Social media, maybe it doesn't work so well for certain cohorts of patients. We need to understand that everyone is clear why they are engaged. So some patients, one of our feedback when we first started these emergency laparotomy patient support and engagement groups, it's a bit of a mouthful, but I'll tell you more about the name later. But when we started that, one of the feedbacks about expectations was, I had no idea what to expect. One of them was, I thought I could come and talk to a surgeon. So they were seeing it as a follow-up appointment. So you have to be quite clear about why you are doing something with your patients. We have to make sure that they have the skills so they're enabled to be a part of quality improvement. We bandy around PDSA cycles, process mapping, QI. It has to be turned into a language that's meaningful for our patients to make it work. So giving them clear and easy information. And when you do something, you have to share it with your patients to say if it's worked or not. So they have to be an active part of that and make sure that they can have a say in the decisions right from the start of developing whatever improvement you're trying to do. So in the 60s, a chap called Einstein, he wrote about citizen participation and the levels of which people want to be involved. And this is important because there's different levels. They can be involved with the direct care, so shaping what actually happens when they come into the hospital, right up to being a part of policy making. And that's incredibly important. But the different patients who might want to be involved at each level need to be understood. Because not every patient wants to be involved, and neither should they have to be involved, and neither should they be expected to be involved. And that's something that's important for us to understand, because even though we are working hard with our shared decision-making, and we're working hard to include patients, what we're learning from some of our emergency patients is they don't want to be involved more than once. They don't even want to be involved or ever think about their emergency surgery again. They just want to get on with their life. So even though we want them to come, they might not want to join in. And then when they are part of it, how much are they involved? We are getting good in quality improvement and research and other things in consulting our patients. So we will consult them. But that's not necessarily involving them fully. We can learn from them, but actually to involve them fully, so it's true patient involvement in quality improvement, means they have to be a part of the design, the production, and perhaps even the delivery. So there are some really significant challenges. And I'm going to talk specifically about emergency surgical patients because I'm quite interested in emergency laparotomies. But it's slightly different to elective surgery and elective conditions. Most of the patient engagement work and patient involvement work and patient focus groups and support groups and charities are set up around long-term conditions that don't present in an emergency. We do now hear more about stroke and about sepsis, and the work that Ron Daniels has done with sepsis is absolutely astonishing, engaging our patients with all sorts of strategies to do so. But dealing with emergency surgical patients is difficult. Patients don't feel equal when they're critically ill. They're not ready to be equal. And when do they become equal? And when do they become well enough or recovered enough, not just physically but emotionally, to be able to be a part of driving change? And that's something we're currently learning from our emergency laparotomy patients in Medway and in other places. So when do you ask them? When do you ask them about their experiences? And what support do you need to give them to make that meaningful? How can they be involved in emergency care? Well, actually, with quality improvement methodology, they have been incredibly helpful, and I'll talk a bit about that in a bit. How do you find the right patients? So there's something called tokenism with involvement. So sometimes we make assumptions about our patients that they're not health literate enough, or they aren't enthusiastic enough, or we make assumptions, and then we would just consult them on a token level. And that's a challenge that we need to overcome. We have to have a diversity of patients in all ages. And emergency laparotomy patients in our NELA database run from 18 to 113. You might say, who's doing an emergency laparotomy on a 113-year-old? But I'm sure there was some good shared decision-making around that. But we have all sorts. And our emergency laparotomy improvement group and support group, they range from all sorts, from the 22-year-old builder to our ladies in their 30s with kids to our 92-year-old Ernest, all sorts of patients. We have to represent them all and understand their own needs. And again, that's a challenge in emergency surgical patients when you're designing quality improvement projects together, because they aren't a heterogeneous population. They will all have different wants and desires, and that's difficult. So making it meaningful, making it relevant, and making sure that it's really driving real change that works for patients is important. But we also have to protect and represent our vulnerable patients. And there's nothing more vulnerable making than wearing a gown at hospital. As soon as you put on that gown, you stop being that professional person or that influencer, and you just become a patient. So we have to protect our vulnerable patients and help them. One of the feedbacks that we've had is, actually, if I'm saying we should do X, Y, or Z, and I'm coming in to help you do X, Y, or Z, am I accountable? How do you support patients through that? We expect to be accountable because we're paid to be accountable, and we are doctors and clinicians. But how do we support our patients? And that's something that needs some more work to look after them. The other problem is, how much impact does it have involving patients? Now, you might be lucky and you might get a patient like me on your ward who's incredibly engaged, incredibly involved, and you probably can't really see, but thank you, UCH, for looking after me so well as a patient. But I was really excited and engaged to see that they had an emergency laparotomy poster up on their wall on my ward. This was brilliant. So, you know what? You could be lucky and you could find someone like me who volunteers and, yep, I want to be a part of that and I want to be a part of the work you're doing to improve patients. But if you're not quite so lucky to have someone like me on your ward, and maybe it's a double-edged sword having a consultant anaesthetist as your patient, then you need to think about who are you going to find, how are you going to find them, and who could you actually work with, and how can you enable them to do that? Are you making assumptions about patients and their abilities to contribute as you make those decisions about who you're going to ask? And before you do that, you have to think about which smart, specific part of your improvement project do you want the patients to help you with when you do the collaborative working? So at Medway, we have now run 5 emergency patients focus groups or support groups or engagement groups. Now, don't really know what to call them. So we started off by calling it Survivors Club. I thought Survivors Club was brilliant. I thought it was a great title. But on the first focus group, they didn't like it very much. So we changed it, and then it became a bit of a mouthful, and then other people came in, and now we're kind of going back to Survivors Club, and they quite like it. But that comes back to something about how we talk to our patients when they are inpatients. Perhaps they didn't realise how close to not surviving they were. So we've set up our Survivors Club. We've tried to create an open and safe space where everyone is heard and valued. I've had to learn how to chair a meeting of patients of all sorts of different types and backgrounds and ages and viewpoints. And that's quite interesting, but it's massively helped by tea and biscuits. It really does help. It's amazing how much work you can get done with patients over tea and biscuits. I've had to learn to sit back and allow the patients and families to talk to each other and bond before you do any kind of quality improvement work with them. Because actually, when you bring patients, first of all, together after emergency surgery, they really seem to feel that this is their opportunity for a debrief, which they may not have had before, which is important. We've used the standards that NELA benchmarks care about to guide and inform our discussions. So not just the quality improvement, but when we start the discussion with our emergency laparotomy patients, we tailor it around those standards that are familiar to you. We talk to them about risk. How did we talk about risk with you? We talk to them about, did you see a consultant? We talk to them about those. We use those to guide the patients through the discussions. And I bring with me my surgeon, critical care nurses, stoma nurses, dietitians. All of these people are starting to come in to talk to our patients as well. So it's about creating a safe and informed space so that the patients are informed and able to become more health literate, I suppose, understand our needs to be able to drive the quality improvement, which is really important. And we have to value the contributions they make, because inevitably, even the contributions that I initially think, what are you talking about? are really, really important. And I hardly ever have to think that, if I'm honest. So off we go with our focus group. You can see we have all sorts. This is my good friend and colleague, Neil Kukraja, who's one of our consultant surgeons who's driven this with me. And it's really important to have that multidisciplinary team to do that. We also have our trainees, our junior doctors, Maria Long and Sophie Williams, surgeon and anaesthetic registrars, who have been really a key part in helping us run these focus groups. And they've grown to love it, which is really interesting. So we have our focus groups, our support groups. We get together, we do a bit of a chat. And probably, so the way we contact our emergency laparotomy patients is by using the NELA database. So each month we've tried to look at how do you get patients, how do you find your patients to do this quality improvement work? Well, it's a challenge. So we use the NELA database. We started by trying to give them letters on the ward when they went home, but junior doctors were forgetting to give the letters, or then they waited until 8 o'clock to go home and the letters weren't there. So we've started to now send out the letters using the NELA database to do that. It's a part of the expected route of care, a pathway of care at Medway, that you will come to one of these groups. So that's how we can send it out to them. About 30 to 50% of those contacted attend. We're still learning about what the perfect timeline is to ask patients to come to these to help us, because actually they've had a major insult and we're still quite early days to understand whether people might come further down the line, longer term, rather than in the immediate time after surgery. All sorts of people come. They bring their friends, their families and their children. Some people only come to one meeting because they feel that's all they need. Others come to every single one. And we talk about all sorts of things. Bowels and their function is a huge topic. We talk about that all the time. Nutrition. What do they eat afterwards? Lots of people don't understand what they could or shouldn't eat after their emergency laparotomy surgery. Sleep. Personal issues, marriages falling apart, people losing their spouses because they can't cope with a stoma bag. We talk about all this. And as the meetings go on and we talk about it and they become more of a safe space, then the improvement ideas start flowing and they start coming out. And that's what's so important, is giving them the time to debrief, to listen to each other, and then they have their Me Too moments. That happened to me too. And that's such a powerful sign of where you need to drive your change. So some results from in anticipation of NELA in September. Preoperative risk assessment and documented preoperative risk assessment is one of the standards that we will audit care against. And there's a great improvement over the last 4 years nationally. And understanding your local data as well, you can see what's happened in your own hospital about the pre-assessment of risk for these patients, which is a cause for celebration. And we've done really well at our hospital about preoperative risk assessment. But when we were talking about this in one of our focus groups, there was a couple sat opposite me, an elderly couple, and we were talking about risk and how do we talk about risk with patients. It was a great discussion. And they held hands. They just reached really quietly and held each other's hands. And afterwards, when I was talking to them, they said, but I had no idea that I could have died. Their preoperative calculated risk of death within 30 days was 73% when I looked back on the NELA. How did they not know? So whilst we were patting ourselves on the back, saying we're getting really good at doing this before surgery, we weren't communicating that with our patients. And the first time they understood how high risk their surgery was when we were talking to them. So that gave us a stream and an idea for some quality improvement. Critical care admission. Well, again, everyone's doing much better admitting their patients to critical care. It's still an area that needs a lot of work in some areas, but at Medway, we're really good at this. Most of our patients now go to critical care. Brilliant. But for our patients, our area now that we're going to focus our quality improvement on is it was really frightening to leave HDU and go to the ward. So thinking beyond just, great, aren't we doing well with our standards? They're terrified when they go to the ward and they stop having one person really looking after them and seeing consultants 2 or 3 times a day and seeing junior doctors bobbling around all the time to go to the ward. Where sometimes you may as well be at home, it feels like, in one of the patient's words. So this has helped us think about our next area of change, but it's also given us quite a lot of power because that's patients talking to us. And so I'll tell you what we'd like for that. Consultant presence. So this is, again, one of the standards that we are really keen on for our patients. And it's at its highest levels now since the audit commenced for both consultant anaesthetists and surgeons, although we're being beaten by the surgeons anaesthetists. So come on, we need to be in there. And this is really important because when we talked about this, they were so relieved, our patients, to have talked to a consultant surgeon, to talk to my consultant. I've spoken to my consultant about my care before the surgery. That's a really important message, because that's why we all get out to go to work, isn't it? Because we want to make a difference for our patients. So when you're trying to encourage your consultant colleagues to see the patients before surgery, how powerful is it about understanding what that means to the patients? So how has this helped shape our quality improvement efforts? Well, it is a challenge, but probably one of the biggest things coming out of it is how we are trying to drive, and I hope we're winning for emergency laparotomy nurses in our institution. And this comes from that direct quote about how frightening it is to step down from intensive care HDU to the ward. We need some kind of continuity there, and how powerful, it's been incredibly powerful to go to our executive nurse to say, this is what the patients want. This isn't just us saying this. This isn't just some kind of thing we have to do. This is what our patients need to keep them safe. They've been actively engaged and involved and edited our patient information leaflets for emergency surgery. In fact, to the point where we're almost abandoning our big patient leaflet before surgery, because they've designed this roadmap of care. So what they said was, I'm too sick when I come in. I'm too poorly. I can't look at a patient information leaflet. I don't even remember it. So they wanted a one-stop shop. This is an edited version at the moment. It's the current edit. So we PDSA stuff with our patients of how they want to understand what happens to them. So from when they come in, they just want to know a roadmap from when they come in at the top to when they go home. And so that shaped how we're giving our information to our patients. Communication of risk. So training our doctors in how do you talk about risk with your patients. It's given a really loud voice, a powerful, strong voice, the patient's voice, which should always be the most important thing for us in our work. When we talk to our executive teams, and when we have to deal with that sludgy mid-layer of middle management whose first instinct is to say no. If you can always bring it back to true what your patients want, then that can make a difference. So, impact is important. We need to understand what the impact of this is, and this is a challenge for us. We need to understand the effects on the individuals involved when they're part of it. And I think we still lack clarity on what the real true effect of involving patients in quality improvement is. So we need to have some strategies to measure this. But ultimately, we need you to grow this and to understand it further, to understand the challenges and to overcome the challenges of engaging patients with quality improvement. We need you and we need your patients. So this is a call to you. If you can do it, set up your own survivors club or whatever they want to call it. Let us know at NELA, and we have the toolkits to help you. And let's collaborate to grow this support network, to grow the improvements for our high-risk emergency laparotomy patients and give them the voice that they deserve to have, so that we can hear them and we can make changes. Because every time you collect a dot of data, it represents a patient, and it represents a patient who has a family and who has a mum, a dad and children. So collaborate, and I look forward to hearing from you. Thank you.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.